Hello everyone, this is Adip. Welcome to my channel Movement Science. In today's video, we will be covering how to take history and we will focus on subjective history, and this will be divided into two parts. Part 1, which will cover your basic information, structure, is it required or not, history of present illness and how to narrow things down, and then red flags and other medical condition. In part 2, I will cover more of patient-centric approach, and then we will combine both these approaches to get a nice holistic overview of patient's condition. So without any further ado, let's get started. So first, starting with basic information, this will have your patient's name, date of birth and address. These will be the most important things that you need to collect. After that, you'll have your consent, where you'll have to ask patient for consent to assess them. And the second part would be, because you'll be taking down the information, you'll need also consent to collect the information and store the information. Now, once these basic steps are done, we will move on to structure. Now, is structure really required when you're doing a subjective history? It has its advantages and disadvantages. Advantage is that if you have a structure, you'll make sure that each and every point is covered and you're not missing out on any important thing. Whereas the disadvantage of this approach is it will feel very mechanical and the conversations might not flow, which means you might not really connect with the patient and build that trust, which is very important when you're treating a patient. And this is where a slightly different approach comes into play, which is a semi-structured approach. What you can do here is you can let the conversation flow, but also have these certain pointers which will kind of anchor you back to these main points that need to be addressed. And that's what we are trying to uncover in this video, how we can bring some amount of structured to an unstructured assessment. So let us go on to the notes and see what we have discussed so far and take it from there. So if you can see over here in subjective history, first was the basic information and consent form, and then is the structure required, and it has its pros and cons that we just discussed. Now, going to a semi-structured approach, what we would start with is a very open-ended question. For example, hi, how can I help you? A very simple question like this will allow the patient to really open up and tell what are their concerns, right? And we will let the conversation flow, let the patient say whatever they have to say, and then once they have finished talking, then we start narrowing things down by asking very specific questions to eventually build a nice story which will help patient make sense of their pain and help us to make sense of what is happening and what we need to treat. Now, along this continuum that occurs, where you start with open-ended question and end with a nice story which explains everything, there is this mid portion which really is, I think, the most important part of the assessment. That is letting the conversation flow and narrowing things down. And this can be done with very specific questions that come under your history of present illness and pain behavior. Now, this would be onset, when did the pain start, the mechanism of injury, how exactly did it happen, the area of pain, the nature of pain, how it has been progressing, if they have had any previous episodes or any treatment around this condition, the pain behavior, that is basically what aggravates the pain, what makes it better, and how much would they rate it from scale of 1 to 10, that is visual analog scale, the type of pain, severity, if they see any pattern in pain throughout the day, that is the 24-hour pattern, along with other associated symptoms like numbness, weakness, and balance. I really believe that our ability to bridge this gap between free flowing conversation and narrowing down to get a nice story improves as we do more and more assessments, because we have more experience and we have seen more patterns. Now, let us understand this process and what exactly happens over here by taking a simple case. On one hand, let's take ACL injury, and on the other hand, let's take Achilles tendinopathy. So in case of an ACL injury, a patient might come to you saying that he injured his knee while playing football, whereas in case of an Achilles tendinopathy, a patient might come to you saying he's been running and practicing for a marathon and he has started developing pain or discomfort at the back of his heel or at the bottom of his calf. This was the free flowing conversation, and they might have given you some more details, but using the specific pointers, we will try to narrow things down and come to a diagnosis or get an idea of what's exactly happening with the patient. So, in case of ACL injury, you would ask very specific questions about mechanism of injury. If they twisted their knee, you'll ask the previous episode if they have had any previous episodes like this. What was the type of pain? Was there a lot of swelling? And also if there is any instability. So these specific questions will help you narrow things down and come to a diagnosis in case of this knee injury. Whereas in case of Achilles, more relevant question would be to make sure that there was no specific mechanism of injury and it just came on by itself, which will make you lean more towards tendinopathy, right? Also, the nature of the pain, if they start running and after running for few minutes, if the pain sort of gets better, we know that tendons have the tendency to do this. As they warm up, they feel better, so again we are leaning more towards tendon. Also, progress, how the pain changes or has been changing in past few months, will also give us an idea about what structures are involved. So you see, different pointers will help you narrow things down and come to a specific diagnosis. And again, this ability improves as we do more and more consultations, because we start picking up on these specific patterns, and then these patterns help us make sense of what is exactly going on. So far we have covered a bigger picture, that was asking the open-ended questions, letting the patient speak and letting the conversation flow, and based on the information that you get from the patient, you start narrowing things down by asking specific questions and then using the information to build a story. Now let's go ahead and cover some of the basic routine questions, that is screening for red flags, where you will ask questions about recent infection, saddle anesthesia, history of cancer, bowel and bladder dysfunction, neurological symptoms, fevers, chills, sweats, and unexplained weight loss. This will help you rule out any serious pathologies that might be going on, and this could be followed by your other medical conditions as well, that is your threads related to thyroid, heart, respiratory conditions, epilepsy, allergies, diabetes, strokes, and seizures. So, this will make sure that you are not missing out on any significant medical or serious pathologies. And I always like to club this with other relevant injuries, because in keeping with the themes of biomechanics, we know that a knee injury can affect the joints above or below it, and vice versa, right? So it's a very important part of subjective history that needs to be looked at. So that was the main information that I wanted to cover in this video. To summarize, we are looking at the basic information in consent. Then we are not sticking to a very structured approach. We let the conversation flow by asking open-ended questions, and then slowly start to narrow things down by having these pointers by your side. And once you start to see a pattern, you sort of build a story for the patient and for yourself, and this would be a big part of your assessment as well as treatment, because it will help you make sense of what is going on with the patient as well as the patient as they tell you everything, and you start pinning them down at specific points. And finally, we can never miss out on red flags to rule out serious pathologies and other relevant medical conditions. This was part 1 of the subjective history taking. In part 2, we will cover more patient-centric approach, where we will cover the psychological aspects like stress, what their beliefs are, what they are expecting out of the treatment, and also understanding their goals and setting realistic goals with them. I hope that you found this video helpful and it improves your subjective assessment, which would mean better consultation and helping your patient make sense of their pain and helping them overcome it. So with that, we finish off this topic. Stay tuned for part 2, and thank you for watching.